Now we're going to briefly talk about post-intubation management. You all should be pretty adept at this already. And just to reiterate, we should be using and documenting a RAS score, a Richmond Agitation Sedation Scale score. And our goal is moderate to deep sedation. It's okay for a patient to flutter their eyes, to briefly open and close to stimulation, but they should not open their eyes and make eye contact. They should not be alert. So aggressive post-intubation management is key to help prevent any psychological trauma to that patient. Now, if your patient starts to breathe again after post-intubation management, you might see this little dip in the center or somewhere in the waveform of your capnography. This is a curare. I think it's pronounced curare, cleft, indicating diaphragmatic contraction. And you can also see on your ventilator screen, a diaphragmatic image will pop up here, and you can also see those arrows under the pressure waveform when there's a spontaneous breath. It's not necessarily bad that the patient is breathing spontaneously on a ventilator if they're sedated well, especially if you use ketamine to dissociate them. They could still maintain some spontaneous breaths, but if there's an increase in them, it could be an indication that the sedation is wearing off. So pharma that we're going to administer for post-intubation sedation. Now, we want deeper sedation if the patient has severe TBI or status epilepticus. Now, remember that we are not paralyzing these patients after we intubate them. That is not something that we should be doing. So you can use ketamine and fentanyl, or this should say ketamine and fentanyl, or fentanyl and Versed. Now with the fentanyl, just push it slowly. Don't take 100 mics and be in a hurry and slam it in. So to reiterate again, that the duration of action of ketamine is longer than the duration of action of succinylcholine. So that is good. Now, special scenarios. These are patients where you want to pay particular attention to how you manage them during this procedure. Traumatic brain injury has in patients with traumatic brain injuries, we have the opportunity to improve their outcomes or severely increase morbidity and mortality with them. And expertly performed RSI and intubation can improve their survival rates, or it can make it worse. So the thing that really might hold us up here is the application of a cervical collar. Now, a cervical collar can increase intracranial pressure in patients with TBI, so we want to make sure that it's on loosely. But also, when we go to intubate, it can limit jaw manipulation. So if we want that mandible to really open up as we're doing scissor, we want a wider view in the mouth to be able to get that blade in. And we also want to be able to distract that jaw anteriorly a little bit to get a good view. So it is appropriate to loosen that cervical collar. Now, what kills patients with traumatic brain injury? Hypoxia and hypotension. So if I am torn between putting this patient in a proper sniffing position due to a possible cervical spine injury, or properly oxygenating and pre-oxygenating them, I'm going to choose the pre-oxygenation. I'm going to position them as needed. Now, again, we're not going to do this routinely. We're going to try to avoid it, but there's little evidence that putting them in this position causes harm. But you know what does cause harm to patients with spinal cord injuries? Hypoxia and hypotension. We also want to elevate the head of the bed. Now, we can keep the spine neutral and in line with the torso or the head of the bed elevated. After intubation, the patient should remain at least 30 degrees. It's been a long-held myth that ketamine is harmful, and I think I've already covered this. And again, deep sedation for these folks. Asthma and COPD patients deserve a lot of respect when we're performing RSI on them. They can rapidly desaturate faster than a normal patient without this pathology. So they can also become very hypotensive because they require a lot of cardiac preload. So we want fluids connected, running under pressure. So if you can tell a pressure bag is something you want to make sure you have, and it's going to be on the bag and up to 300. Now, you can still titrate if you don't need the fluid running in that fast. You can still titrate your roller clamp, but we want the pressure on, pumped up, ready to go, and we need the ability to open up that roller clamp and give fluid under pressure when needed. We want a low threshold to initiate vasopressors again. Epi is a bronchodilator. It has bronchodilatory properties, so it would be helpful in these patients. If after you intubate this patient, or really almost any patient, but especially your asthma and COPD patients, if you have a sudden decompensation, it could indicate a few things, but we want to watch out for dynamic hyperinflation. So you can see on the graph here that after each subsequent breath, there's not full exhalation. So an additional breath stacks on top of that, and again, there's not full exhalation. So the lung volumes keep increasing with each subsequent breath. That leads to dynamic hyperinflation, increased intrathoracic pressure pushing on the heart and especially the large vessels, inhibiting venous return. So what do you do in this situation? Well, you slow your rate down and you pop off the BVM to let the air escape. Something else that could be causing this is a pneumothorax. So sudden deterioration after intubation in a non-asthma, non-COPD patient, especially if they have chest trauma. A patient with chest trauma could be breathing well before you intubate them, and when you convert that negative pressure to that forceful positive pressure breaths, they can rapidly decompensate. Also consider forceful exhalation on these asthma and COPD patients if you suspect breath stacking, which is where you apply manual pressure to the chest. Now, once you intubate a patient with asthma, COPD, pulmonary edema, or anything, that's not the cure. The disease progression is still there. That's not the treatment for that. The treatment for asthma, COPD would be bronchodilators, steroids, magnesium, epinephrine, all of those things. We can make the problem worse by actually putting them on a ventilator. So you want to avoid that if at all possible. You want to treat them as aggressively as possible if you think you're going to need to intubate that person, to try not to. So our goal is actually not to intubate these patients. Now with pulmonary edema, you know that they're going to require higher PEEP, higher FiO2, and we're going to have to maintain that PEEP. So if you got a patient with severe acute pulmonary edema or SCAPE, sympathetic crash and acute pulmonary edema, they're not going to improve with passive oxygenation via a nasal cannula and non-rebreathers. So we're going to have to use a BVM with a PEEP valve and a nasal cannula on underneath it. Now, again, the same is true in pulmonary edema as in asthma or COPD. We want to try to avoid intubating them because they are going to rapidly desaturate. But in this patient, that's going to require higher FiO2 and PEEP, we want everything at flush rate. I want my nasal cannula at flush if possible. I want my BVM at flush. If I have to choose, if I only have one regulator that will go to flush rate, then I'm going to choose my nasal cannula because that's going to be delivering oxygen while I am intubating. Metabolic acidosis. So if you have a patient that you suspect has diabetic ketoacidosis, salicylate poisoning, or rhabdo, you have to be very, very careful. These are the P patients in your HOP killers, the low pH. Again, you want to try to avoid intubating these patients if at all possible, because to correct the metabolic acidosis, it's going to take a long time and not something that we're going to be able to immediately correct. The best that we can hope for is to try to maintain the compensation that the patient's maintaining as good as possible while we try to perform the intubation. So these are patients that you would want to maintain gentle hyperventilation to blow off that CO2 to maintain that compensation. But what does that increase the risk of when you're trying to intubate? Gastric insufflation and aspiration. So this is almost this is a lose-lose scenario. There's no win-win about it. And obviously they're going to need IV fluids. Pulmonary embolisms also deserve special attention, because if a patient has a massive PE to the point where you think that you need to intubate them, then intubating them or providing positive pressure ventilation or fluid, it makes everything worse. No matter what you're going to do, you're going to make it worse. So be aware of that. I have witnessed this personally. We had a patient that was alive with a PE, respiratory failure. As soon as we intubated her, she went into cardiac arrest. But with RSI, not only are we intubating them, we're giving vasodilatory medications. We're completely removing their compensatory capabilities. We're increasing intrathoracic pressure, which is already going to worsen. It's going to worsen an already strained right ventricle. Okay, and we're increasing the afterload by increasing the pressure in the lungs. So if you have to intubate these patients, use pressors. Try to not deliver high peak airway pressures. Fluids, surprisingly, can make it worse. Okay, and yes, these are just nightmare patients that you want to try to avoid intubation. Lastly, let's talk about documentation. So, if 2 attempts are required, document each RSI attempt separately so that we can have accurate documentation on how often we're having to perform it twice. And just go ahead and document your intubation attempts separately. Document honestly and accurately. We're going to start off with a small cadre of folks that we're credentialing to perform this. Now, that doesn't mean that you can't do any part of the procedure, but this person has to be there because they're being signed off by our medical director to be able to do this. They just have to be there. Everyone's getting trained on it, but they have to be there. Document vitals regularly. You're going to have to keep track of everything. So if you want to use the event tab on the monitor, that's fine. You need to document the time that you administered the induction accurately and the time that you administered the paralytic accurately. This might be a quick boom, boom. If you give them in quick succession, then fine. It's pretty easy. If you're performing RSI and giving these medications in quick succession, it's easy to document that time with one event plus a few seconds. 10 or 15 seconds. But if you're delaying and you're giving the sedative or the induction to pre-oxygenate, so you perform delayed sequence intubation, then you're pre-oxygenating them for 3 minutes and then administering the paralytic, you need to document those clearly separately. And what we're going to do is for each RSI, we're going to pull the SpO2 trend, create a graph, and we'll mark the nadir, so the lowest SpO2 and the lowest blood pressure that was obtained in the procedure. Document any complications that occurred. Document methods of confirming airway placement. And a RAS score should be documented both before and after the administration of sedatives. And our standard for documenting a tube depth is at the gums, as well as confirming bilateral breath sounds and of course waveform capnography. Here's an example of what all of the things look like that we're going to be tracking. I won't go over each of these, but we plan on tracking the RSI and non-RSI intubation separately. All right, closing thoughts. My closing thoughts are this, and then I'm going to play this video. This is a very high-risk procedure, and it requires good clinical gestalt, good clinical decision-making. I can't cover every single possible scenario that you're going to encounter when performing RSI or DSI. Remember, our goal is to make the patient better, not worse, to be able to safely facilitate transport and get that patient to their final destination. We have the ability to do good, to do things that help the patients. We also have the ability to do things that could be potentially deleterious, and that is entirely dependent on your knowledge and your skill and your good judgment. So when thinking about performing RSI, ask yourself, is this RSI better performed in the hospital or in an ambulance? And I think if you do that and you just look at the whole clinical picture of what's going on with the patient and not just do I need a tube, we're going to do fine, and y'all are going to do great. So now I'm going to play this video. It's the Elaine Bromley case, and you've probably seen it before, but it deserves watching over and over again to remind us of what can happen if we hyper-focus on passing the tube instead of ventilating this patient.
My name is Martin Bromley. I'm dad to 2 young children, Victoria and Adam, and this is the story of the death of my wife, Elaine, who died in March 2005 as a result of an attempted routine operation that went wrong. There's some confusion about the precise time, but we know that 6 to 8 minutes in, a number of things were happening. The anaesthetist had already started to attempt to intubate Elaine. The oxygenation was still at 40% or lower, the heart rate was falling. The ENT surgeon waiting to perform the op came into the theatre. An anaesthetist from an adjoining theatre became aware of a commotion, and he walked in to see what could be done. And at least 3 nurses answered a call for help. And what happened is that the 3 consultants continued with the attempts to intubate, and they used a variety of different techniques and a variety of different pieces of equipment. The nurses, meanwhile, performed some tasks under their own initiative. But what we can say is that 10 minutes in, with hindsight, this is a situation of can't intubate, can't ventilate. This is a recognised emergency in anaesthesia for which guidelines exist. We're now 10 minutes into this attempted procedure. The patient, my wife, is blue. Her oxygenation is 40% or lower, and it has been for 6 minutes. The anaesthetist has 16 years experience, and he is regarded as diligent by his colleagues. The ENT surgeon has over 30 years experience. The other anaesthetist has additional skills pertaining to difficult airways, and 3 of the 4 nurses are all experienced in their job. And it's perhaps worth just wondering at this stage what was going through their mind. The intubation attempts had failed, the oxygenation was very low. What we know actually happened is this point in, 10 minutes for a further 15 minutes. The three consultants would appear to have continued with their attempts to intubate to the exclusion of any other option. And that at the end of that 15 minutes, we're now 25 minutes into the whole procedure, they eventually get Elaine's oxygenation to 90%, but she's actually been at 40% or lower for a total now for over 20 minutes.
Keep going. Can we get above 90?
Nope, she won't go up.
No, you got 90 though, that's better.
I don't think we should carry on with the operation.
No, I agree, I think we should abandon it at this stage.
Okay.
The airway itself is not secure though, and so they fiddle around a bit more, and in fact her oxygenation falls again below 90% for a further 10 minutes, and finally by the time we're 35 minutes in, they seem to make the decision that the best thing is just to let her wake up naturally.
Let's wheel her back, quick as we can.
And they transfer her to the recovery room. She lays there for an hour and a half, and of course she never wakes up. Based on the evidence from the inquest and from Professor Harmer's report, the lead anaesthetist, if I can call him that, in his own words, lost control. There was a question mark in the inquest about who people felt was in charge at different points. There was certainly a loss of awareness, an awareness of time, but also an awareness of the seriousness of the situation. If you like, the awareness of what was happening wasn't shared by each of the consultants. There was certainly a breakdown in the decision-making processes, and it would appear that the communication processes dried up amongst the consultants. The story with the nurses is very different. The nurses were generally aware of what was happening and what needed to happen. When I said to you that 6 to 8 minutes in, those three nurses arrived, one of them asked her colleague to go and fetch the tracheostomy set. There was already a quick trachea kit in theatre. She went out, she collected the tracheostomy set, she came back in, she announced to the consultants that the tracheostomy set was available, and there was no response. One of the other nurses who walked in immediately saw Elaine's colour, immediately saw the vital signs, and walked out again to phone intensive care. She phoned to check that a bed was immediately available. She came back in and she announced to the three consultants that a bed was available in intensive care. And in her own words, they looked at her as if to say, "What's wrong? You're overreacting." She actually walked out and cancelled that bed. At the inquest, 2 of the 4 nurses stated that they knew exactly what needed to happen, but again, to quote from the inquest, didn't know how to broach the subject.